My name is Natalie Haslam, and I work at GMCVO alongside Kat and Beth, who's here as well. And we're the team that work on the Health and Social Care VCSE engagement project that hosts these sort of sessions for the sector. And our project comes out of a memorandum of understanding that was signed between the VCSE sector and the Greater Manchester Health and Social Care Partnership to increase the role and engagement and involvement of the VCSE sector in the work of the Health and Social Care Partnership to implement health and social care delivery activities across Greater Manchester for the improvement of the population of Greater Manchester's. So today's session is off the back of the NHS report that was sent to all of you that was published late last year. And Greater Manchester has been on a journey of health devolution for several years and moving towards integrated care systems, and this is kind of moving on to the next phase of things. So just to let you know that there's a note that's come up saying that we're recording today's session. So the first part with the presentations and the Q&A we'll be recording. Slides will be shared after the event. In terms of the agenda for today, Kat, can you just pop it on the screen?
Yep. Can you see that?
Yes, thank you. So we've got, and thank you for coming along, Warren and Mike. We've got presentations from Warren Heppolette, who is the exec lead for strategy and system development at the Health and Social Care Partnership. And then Mike Barker is the Director of Health and Resources and Chief Operating Officer at Oldham Council and the CCG, who will then be providing more of a locality perspective on things. We'll have a quick break and then we'll move into some discussion sessions, which I know that everyone is tight for time, but if you are able to stay for those discussion sessions, I think it would be really good to get as many voices into that conversation as we can do off the back of the presentations, and then we'll just do a quick feedback and wrap up session at the end, and hopefully you'll be leaving on your way well before the 4:30 that we've put in the invite details. So yeah, I've kind of explained a little bit about why this session, but I think VCSE, the role of the VCSE sector in kind of health and social care in Greater Manchester, particularly in light of the role that many organisations have played as a result of the COVID pandemic, has really highlighted what the VCSE sector can provide around health and social care delivery in Greater Manchester, and that we need to be involved in the conversation about the direction of travel around integrated care. And so Greater Manchester is doing a lot of work to reflect off the back of what this national NHS paper means for the next phase of things. And so we wanted to hold this session to make sure that the VCSE sector is involved in that conversation and that we've opened it out. And it's great that we've got Warren and Mike along to help support that conversation to happen. So without further ado, we'll move over to the presentations. We'll follow that with a Q&A. So if you have got any specific questions for Warren or for Mike, if you could leave that until they've both presented, and then we'll go through and pick up some questions and answers, hopefully then. So Warren, over to you.
I just wanted to ask an awkward question at the start, if I could, because what Mike and I were thinking as we were sort of checking in is that if it's possible, and I'm conscious having seen the slides, that this might be a bit of a pain in the but if it's possible, would it be okay for Mike to go first? Because it felt like it made more sense for us to do kind of place and then system, if you see what I mean, and kind of work out rather than kind of start what might feel like a bit of a distance and then get local after. Would it be okay if we did it in that way around, if we could just orientate the slides like that?
Of course. Yeah.
Yeah.
Thanks for that.
Over to you, Mike, then.
Okay, so I'm grateful for the opportunity. And as usual, things are just a little bit fraught at the moment with lots of different things. So I wrote my slides like yesterday. So I'll share my screen if that's okay. And I think the best I'd say is I want to offer you a perspective. So there are 10 places in Greater Manchester. I think there's something quite important about us all doing the same and similar things, and certainly at least working to a minimum set of standards. But each of those 10 places is slightly different. You know, if you look at Oldham in particular, we have a very rich mix of ethnicity and diversity in our economy, but we've also got a huge amount of deprivation and poverty. As someone who many years ago worked in Trafford, that's a completely different place to Oldham, and the solutions that are in Trafford will not exactly be the same as what needs to happen in Oldham. Equally, I've been in the NHS for a long time, and Warren and I have certainly known each other for a very long time. And the one thing I thought was quite good, to say the least, about the document for NHS England around integrating care was actually really permissive. It's really, really hard to write a policy framework to fit everywhere in the entirety of the country without someone feeling aggrieved that that's a bit too Greater Manchester-like, or a bit too Merseyside-like, or a bit too Lancashire-like. So the fact that someone's pulled that off, I think, is a testament to their ability to provide as much flexibility for local systems to go as far as they can. However, that does pose with it some dilemmas. So I think it's a really good read. If you've not really managed to read all of it, it's about 33 pages. It's a pretty good read. I think I phoned Warren straight after I read it, and both of us said the same. Oh, that was refreshing. Thought it was going to be quite a boring didactic policy document, but no, it's far from that. Actually, it's done in plain English. The other bit I would say is that I spoke to the authors of the document myself personally, and both of them were very, very clear that they wanted this to be something that enabled the future direction as opposed to constrained it. And when I talked to them about what we were doing in Greater Manchester, they absolutely recognised all of that. You know, Warren had clearly done a very good job in bringing them up to speed. And like me, they saw what we were doing, or they saw that document as being a bit of a natural extension of what we were doing in Greater Manchester to give us that springboard for the next part of our journey. And they very much recognise that we're not starting from scratch in Greater Manchester, but there are very, very much places in the country that are starting from a zero base. They don't have, first of all, don't have devolution. Second of all, they don't even have a health and social care partnership, or even a health and care partnership, and they're having to build them from scratch. So what I want to talk to you about is what we're doing in Oldham, and hopefully give you a feel of a little bit of how that fits in Greater Manchester. Let Warren pick up on the nuance of changes that I probably think he will want to correct me on words, but also leave some of the more kind of heavy lifting policy stuff over to Warren, and let him stitch the thing together with his bit. And I want to just start with this. Can everybody see that? If I look at you, Natalie, if you just nod, I'll know that's all right. Fabulous. We're broadly moving to a system approach, and that system approach is something to be organised at a Greater Manchester level, commonly now being referred to across the country as an integrated care system. For my part, I'm interested in what happens in a locality or at that sharp point of the pyramid, and we very much see that as being in a locality, a place where we bring together the health and care system through collaboration, network and alliances, where we join up commissioning and provision, and we connect services at neighbourhood level, not just from care homes and PCNs and neighbourhoods and districts, but also the voluntary sector. And I certainly see a lot less utility in the concept of commissioning as you would know it as a clinical commissioning group, for example, and much more as a strategic planning function that is an enabler and an environment creator for people to be able to get things done and make things happen in their local area. For us, we see that as being orchestrated by a single place-based leader. We currently have a council chief executive who's also my chief officer in the CCG, as well as my chief executive council, and a focus over this next period of time to really start to streamline some of our governance arrangements at system level. the big issue and the big idea, though, for me, is about making a fundamental shift away from reactive care to population health management. Starting to look at what the trends are of the way the population is moving, changing and growing and adapting, and starting to provide solutions to match that. And that shouldn't be just about the statutory services providing those solutions. I think it's about the communities working together with a range of new and different organisations to create some of those solutions. I said this to Warren yesterday. I'm pretty keen that the way of creating a new social contract, something that's really different, that starts to provide people with agency. And I think, you know, our whole approach in Oldham is about creating a thriving community and inclusive economy with cooperative services, and that runs through the core of everything we're trying to do. We spent quite a bit of time over this last period of time really starting to think about, so what does a model of care look like? How might we describe that model of care? And the bands on this diagram are purposely trying to describe the width and depth of some of those sectors, primarily because I think we believe in Oldham we've got a very acute-based system. I think we probably believe that across the whole of Greater Manchester from an Oldham point of view. And what we really need is community assets and a system that enables us to start focusing on reducing health inequalities, brings the wider determinants conversation into the space. So I'll give you a real example of that. You know, there couldn't be a more sharper focus right now about respiratory disease with a pandemic that affects people's lungs and breathing and everything else that goes with it. But respiratory disease is one of the highest levels of early death causes in Oldham. And I'm also pretty certain when I look at that data, when I look at what I see every day, we can continue to help people manage their respiratory disease and their respiratory problem. But fundamentally, the cause of it is pretty poor housing in Oldham and its deprivation and its environment. And there are very, very little places where we are able to fully sit down and engage in a conversation about dynamically shifting and adjusting and deploying resources to get better outcomes by focusing on different solutions. And that means that we don't want to keep focusing on just acute-based care. What we want to really start to do is bring more people to the table to think very differently. Equally, I think we are moving into a phase now where myself and a couple of colleagues are just finishing off the governance arrangements for this, where we're starting to talk about three things that need to exist in our economy, which is about the design of services and models of care at scale, the delivery arrangements needed to support them, and then the governance that required to not only bring the organisations together, but to ensure the quality and effectiveness and safety of the services that are provided. And when you start to put together reactive services being a secondary issue and move much more towards population health focus and proactive care, you open up the world of possibility, thinking really differently, I believe, of the type of skills and resources that are required to make that happen. So for us, we want to remain focused going forward on a series of rights and entitlements. So being really clear that everybody who lives in a place is entitled to clear advice on staying well, entitled to access of a range of preventative services, but everybody who's actively involved in things like the NHS is playing its full part in social and economic development and not just focused on health and care specifically, but having a wider brief and remit. We think our challenge going forward, though, is very much around developing primary care because it's quite immature as a system compared to hospitals. There are new organisations emerging in places called primary care networks, but fundamentally we need to simplify, modernise and join up health and care, not just across acute and primary, but across the whole spectrum of it. When you think about the concept of lots of people turning up at hospital as their choice of preferred delivery mechanism, we're also spending an awful lot of time, money and effort on not really tackling the underlying root causes. So we need to use data better. We need to understand how and why people are turning up in certain places and start to think very differently about what the services would look like for those individuals. And in places like Oldham, we've now moved to 5 footprints within our economy. Each one of them is supported by a clinical director from the primary care network, and we're joining them up with elected members and community leaders in each one of those places. And nothing more could be sharper right now in Oldham than that. We've vaccinated over 40,000 people, and we're now at that really difficult place of the very, very hard to reach and convince people. A lot of them from our Muslim community, we're having to talk to them about halal, dispelling myths around microchips and tracking, but getting into some really grainy conversations. We're able to do that because of the infrastructure that we've built. We're working very closely with Action Together, our community voluntary sector partner, and we're doing a lot of engagement with door knocking, and we're starting to have a different conversation with the people in those communities about what the barriers are, and we're starting to see quite a decent shift in attitude towards the vaccine. We would not be able to do that if we just kept planning at a GM level or a pure Oldham level. We have to get down into the detail of understanding what's in those communities and how do we start to have a different conversation with them. And part of the governance that we've set up, part of the shifts that we're making, and part of the pandemic is helping us be quite permissive around that, which is one of the benefits, I think, of what's happening in the pandemic. But of course, we're starting to try and articulate that now in a set of words and a set of documents that actually make sense and legitimize it. I think we need to change some of the more strategic level conversation and how that connects right down to the neighbourhoods and the communities. And we are absolutely starting to understand and learn from our partners in the VCSE sector. What more could we do to bring them round the table, not just at a strategic level, but an operational level in communities, and how might that tie together? And that's often a challenge, not just for the organisations involved, but for some of the people involved as well, because I think there's a real cultural learning divide that we need to get through and past, about recognising that not everything needs great big governance structures. I don't think we're very permissive at times as institutions in the place. So we're starting to engage with people like the King's Fund to think about how might we have a development programme across our whole economy. How inclusive could that be? What would that need to look like in different places? So trying to kind of upskill everybody in the place and recognising that not everybody or not any one person has all of the answers, but collectively we have a range of answers between us. And then finally, just to finish off, and I could have given you 33 of these slides. These are the 7 that I thought might be quite useful to get started in the conversation. I think what we're really aspiring to is, the coalface is this kind of stuff, where at the moment we've got lots of blue blobs. We've got lots of people in these blue blobs doing lots of great things, and whether they're called a community care team or a GP or a practice nurse or a social care team or a hospital consultant or a social prescriber or someone else in the voluntary sector, the reality is, how do we kind of make it so that all of these folks work and operate as one single team? I have a real strong view that we need to be very, very clear about what services we're integrating, and therefore what processes, what people, what teams, and what pathways. And then we need to recognise that the GP and the hospital doctor can't be default for everything. We need to accept that there needs to be a wider role for nurses and allied health professionals, but we also need to realise that there is a much wider role for the voluntary sector. And we've got to find new and different ways, I think, in this phase of harnessing it. A good friend of mine called Stuart works in another place in Greater Manchester, who Warren also knows very well, often describes the NHS as needing to have its heartbeat moment again. And it's not about a physical condition, it's about kind of, we all remember the times when the local doctor knew everybody in the community and all the resources that was available to the local doctor, and somehow over time we've super specialised everything and lost that, which makes our systems quite complicated to navigate through. And we need to find ways, new and novel ways, sometimes using technology, of unbundling some of that work and starting to think a little bit differently, and starting to be a bit less precious about some of the organisational arrangements that are in place, and start to think about what is it that we need to achieve, who are the people that need to come around that, how do we make that happen. And we like to think of that as our way of describing what Team Oldham is all about. Less and less do I sit in meetings now talking about organisations, more and more I sit in places talk about objectives and problems and solutions. And I think sad as it may well be, the pandemic has at least brought a erosion of some of the boundaries. The integrated care document, I think, gives us license and permission to move on from this into this next phase with some confidence and certainty. So I thought I'd stop at that point and let Warren take over from there, if that's okay.
Brilliant, thanks, Mike. And because I'm now doubly impressed because Mike had managed to share his own slides on Zoom, and when it comes to Zoom, I'm kind of gold medalist in an epitaphlon, and can't quite manage it myself. So I'm now kind of playing for time. Brilliant! While Kat sorts it out for us. So I think this is kind of picking up, I think, a lot of the same principles and points of emphasis really that Mike made in terms of offering the example of where the thinking was in Oldham, alongside what I might describe as how have we reacted to the national document at the Greater Manchester level. And the key bit, I think, and colleagues on the call today will recognise this, because there is a real risk that we kind of foreground the sort of the structural changes that are envisaged here, and I will touch on the structural changes that are envisaged here. But actually, none of that really matters if there are no relationships. So the kind of purpose of how we need to kind of consider what we do with this, sort of turning of the wheel on how we work together in each of the localities in Greater Manchester, and how we work together jointly across the whole of Greater Manchester, is still about actually how do we take some of the pieces of this changed external environment and use it to deepen our relationships. So it means that we've got to kind of take stock of where we are at the moment. But as Mike said, just to kind of kick us off, we picked up that national document at the back of November, and Mike's absolutely right. I had the same experience reading through it on the night that it came out, and ticking loads of I don't know, kind of small objectives of what I was looking for from the document. And what I was looking for from the document was clarity of emphasis on population health, and not just about how we organise health services. A distinct emphasis on health inequalities, if this was going to be a document that was going to be useful in a post-COVID context. An emphasis on place, and what that means for communities being at the heart of the way that we think about health and care, and us not just moving around the deck chairs of sort of care providers and health and care services, and what that means for the relevance of the health sector to how we support the local economy, what that means for what's our role as much as an employer, and a route through successful education careers, as much as what does that mean for our responsibilities for providing services. And it felt like a lot of the document was distinctly focused on how do we make it easier for organisations to work better together in the interests of the populations they serve. So I was sort of punching the air, as much as you do when you're reading a 33-page document. But I was genuinely heartened by what we'd found. I could see that the journey that we've been on across the 10 districts over the last 4 to 5 years, and the journey we've been on across Greater Manchester, looked like it had been recognised in that document. So we've got to kind of take it at its word and think about where it hasn't offered detail or emphasis. It's up to us to fill the blanks in, really, and do it on the basis of what we think makes us work better together, what we think best serves our communities and our residents. So I guess the key point is that regardless of the technicalities of what we might read in this document, it'll all come back to if we've got good relationships, and we understand what our common purpose is, and what our shared ambitions are, we'll find a way of making this work, and continuing on the journey that we've been on for the last few years. If we just jump onto the Next slide, please. So when we kind of picked up the new national document, we're taking account of actually what did we say about our objectives when devolution was first envisaged and enacted in 2015, 2016. And that list of objectives in the green box on the right hand side there was kind of what we wrote then those few years ago. And actually, we still thought that felt like it had some resonance and relevance. And I remember, and there are definitely a good number of colleagues on this call who were part of the same conversations at the same time, I think. And one of the sort of the key starts to any conversation that we were having then, which I still think is the same now, is us asking the question, who can contribute to benefiting somebody's health, and how do we connect them? And that forces us to think outside of health and care services. Think, as Mike emphasised, in terms of what does that mean about the nature of our relationship across other public services like leisure providers or housing organisations? What does that mean in terms of a community's control and influence over the health of its own members? What does it mean about the role of the VCSE as a part of that community, but in so many cases actually as a supporter and provider of services to that community? So that we were kind of open really on saying, actually, if we were really serious about improving the health and well-being of all of our residents, it means we'd have to get really serious about recognising the limitations against that ambition of formal health and care services, and starting to unlock those contributions that address the full range of determinants of somebody's health. So it was an important step, I think, for us to go back to some of those foundation documents in 2016 and say, are these still relevant? And it'd be really good, I think, if as part of our kind of conversation today, we applied the same test, really. So, in terms of that journey that we set out on 4 or 5 years ago, does it still feel like actually that's the right journey, and this is about kind of completing that process, or does it mean a fundamental reset? And if it's somewhere in between, where do we think our kind of points of opportunity are? Which are the things that have gone well in some places, but not been fully spread? And how do we develop those? Which are the things that have felt like a barrier right the way through? And how do we identify those and overcome them? And obviously they'll have relevance at different kind of geographical levels. So there are some of those kind of opportunities or barriers that'll be relevant to the way that we work in neighbourhoods and in individual localities, and we can between us this afternoon we can definitely get into that. Similarly, at the Greater Manchester level, and how we work together through this assembly, through the VCSE leadership group, what that means for the way that we organise priorities and ambitions at the Greater Manchester level, and how we deliver change and how we identify the need for change at that level. And also, I think at the national level, what in the context of the legislative framework that we exist in feels like a barrier to our being able to work together well, and in the local context, because one of the things that we always try and do in Greater Manchester is not just read what comes out nationally and understand how we comply. We want to form our own view on what doesn't work for us in terms of the conditions we're expected to operate in. And if that means that there are changes that are that are to do with changes in the law or changes to the regulation of organisations and institutions, we should identify them and lobby to affect that change. If we move on to the next slide, please. So again, in the same spirit, really, of rethinking our particular set of objectives from those foundation documents in the sort of devolution journey, we were also thinking about actually how do we locate a core set of key priorities, and kind of engage on whether these feel like the most relevant ones. And what we'd identified, and I think this has been quite a consistent feature through most of the last year, really, as we've kind of understood and been confronted with the reality of the extent to which COVID has absolutely kind of exposed and pursued the inequalities that exist across society, and Greater Manchester being at a kind of profound receiving end of that inequality. So it feels like the first organising principle of the way that we think about setting priorities and establishing plans, programmes, and ways of working across the coming period is a distinct focus on tackling inequalities and transforming the population's health. And again, that follows the same principles that isn't something that is within the remit of the statutory sector working on its own. I think this is all of us. Second thing was around. It says that the language is quite funny there, actually, and a bit odd. And it's guaranteeing constitutional standards and eliminating unwarranted variation in care. And again, if we were picking up the prompt from the post-COVID recovery, one of the key things that we would emphasise is the extent to which people's care, beyond a response to those affected directly by the pandemic, has been disrupted, delayed, and interrupted, and that will create a significant burden across populations of people who should have had care for other conditions and have seen that interrupted, delayed, or blocked in some way. And we'll see it obviously in quite stark ways in terms of waiting times for planned care and delays in waiting times for things like cancer care. So there'll be an immense priority around recovering some of those core services and getting things back on track beyond the phase of the pandemic. We'd also thought about some of the things that are unusual or perhaps unique in the Greater Manchester context that we think should be emphasised in our priorities going forward, and in particular the opportunity that we've got to connect our academic assets across the 4 universities with industry partners and with the health and care service, and ensure that Greater Manchester is a place that is on the front foot in terms of innovation, and that our population benefits first from some of that innovation as well. And then the fourth thing is, I guess, the kind of the reality check, really, of we don't really know what the economic climate is that we'll be going into post COVID, but the clear expectation is that it'll be cold and will figure potentially a continued period of austerity, in particular in relation to public service funding. So our statutory organisations will be under significant economic stress, and we'll have to take stock of what that means in terms of the sustainability of services going forward. So these were the things that were at the front of our minds, I think, as we thought of what would be the headline priorities going forward. So there's a bit, and I guess the reason why I'm emphasising this is because it's a bit more than just sort of changing the governance, letting the adopting the changes that are signalled in that national publication. We've got to turn that system onto what will be the needs of our residents and communities as we come through 2021 and the years that follow. If we move on to the next slide, please. And I've just seen Kat's comment in there, and it's absolutely right. And we can, and I think we spent a bit of the summer and have recognised the financial pressure and the damage and the human pressure that's been placed on the VCSE sector over this period as well. So last couple of bits from me really, and this is I suppose kind of playing directly into what Mike had described, because I wouldn't call it a concern as much, because the national document does genuinely emphasise the centrality of working at the place level, and goes as far as saying that integration, connection with communities in place is the building block of the way that we will organise the system going forward, and we absolutely support that. But it doesn't describe a lot about how that happens. So, as I said at the start, it's up to us to kind of design some of that really, and genuinely take stock. And this is, as I said, this is part of this afternoon's conversation. I think taking stock of where we are now, what we've learned over the way that we've worked together over the last 3 or 4 years. What have been the best bits? What have been the ongoing frustrations, if we can kind of call those out as well. And then think about where do we go in future. So I think what we've tried to emphasise over the last few years is, and Mike set out the sort of position that Oldham's got to, and the position that Oldham wants to get to over the coming period, is a much more kind of human to human and simplified version of place-based working. Where the resources and assets in that place are brought together, where there is the ability to identify and confirm shared objectives, shared ambitions for that place, and pursue them together without bouncing around the barriers of multiple organisations that are facing in different directions. So as much as we can, kind of bringing together the leadership across sectors in those places, making them directly relevant and connected to the needs of that place, and thinking about what's the next stage in our journey to integrated health and care delivery, but done in a way that feels relevant at the neighbourhood level, feels like it's participatory at the neighbourhood level, and spans the full range of health and care services, public services, and the local VCSE as well. What's the nature of those relationships really? What does that mean for how VCSE partners join and support the delivery of some of those services? So some of those conversations that we've had about things like the commissioning framework, and about infrastructure support in the VCSE in each place, is for us to think about, where have we gone to on that journey, who's done it well, and what can we learn, where are we still kind of hitting a bit of a wall in some localities, and how do we support those conversations in those places. Next slide, please. I'm nearly there now. And then beyond the how do we move to the next stage of joint working at the place level? What does that mean for a new model of collaboration at the Greater Manchester level? And that'll be both making sure that we follow our founding principles really about Greater Manchester level working, and that it avoids being a two-tier system. That it's driven by authentic knowledge of and connection to each of the 10 districts. That we build on the progress that we've made around establishing meaningful relationships, joint working, and a bit of innovation in a lot of the kind of the projects and programs we've pursued together over the last 3 or 4 years, working across the VCSE sector and the statutory sector. That we don't drop the connection that we've managed to make in terms of the VCSE's participation in the formal governance at the Greater Manchester level, and obviously we've not spent days and weeks on this. On this work in the meantime, because obviously the system's attention has largely been on responding to the third wave, supporting the process around contact testing and tracing, and obviously mobilising the vaccination programme. So this hasn't been the subject of loads and loads of endless meetings at the moment. So I wouldn't feel that you were behind any particular curve in joining this conversation, if I'm honest. And then final slide, please. And the only thing to say on this bit really is just to recognise that there were a couple of timelines that were set out in that national ICS document, and it's anticipating the legislative change to allow the ICSs to be established to be statutorily established as legal entities, and obviously for Greater Manchester, the legal establishment of the ICS would be at the Greater Manchester level and would be part of the next iteration of what we've built as the Health and Social Care Partnership over the last few years. But obviously there'd be quite a few, I suppose, sort of detailed and technical parts of that transition to establish that body, to understand an appropriate model of governance that doesn't disconnect it from the localities and wider partners across Greater Manchester, that understands the model of clinical leadership, that recognises that if CCGs are no longer there, actually a big part of what we've seen as system level strategic clinical leadership has come from senior clinicians in CCGs, and that's something we'd be keen not to lose and to find alternative means of bringing those into the system. Understanding how money flows in that new arrangement, that will be significant, because it has to be seen as it'll be a key enabler to being able to realise the ambitions at each of the place levels, to make sure that the money doesn't get stuck at the Greater Manchester level, if I'll put it as bluntly as that, which might mean that decision making ends up actually being further away from communities. So I think that's a key test for us. And how we kind of continue to identify, I think, what's the right thing at the right level, what should exist in neighbourhoods, what should exist in localities and districts, and where is there a particular advantage in us doing work together across at the Greater Manchester level. So I'll leave it there, and we can get into any questions that colleagues might have for me and Mike.
Thank you, Warren and Mike, for that. So if you do have questions, if you either pop your hand up, use the hand waving function, or pop something into the chat, and we'll try and get to them all. So there is already one that came up in the chat whilst you were talking, Warren, which is around talking a little bit more about the governance plans, and will there be reporting of spend and team numbers, caseloads, waiting times, outcomes, and including comparisons between localities with socio-economic communities, and that, I think, particularly in respect of mental health services. So I'm not sure how detailed you've got in thinking around things like that and reporting mechanisms and that kind of parity across Greater Manchester.
Yeah, because I think we'd. So I think it's a good question, because if it sounds a bit like what might be behind it is that wish for a degree of kind of transparency and the value of the comparisons, and so I think we'd probably be looking at kind of building on some of the starts that we've made in that kind of territory, really. So when we had, and obviously things like public meetings have been disrupted considerably over the last year, but when we had the Health and Care Board meeting in public, it was a routine thing there that we would include a Greater Manchester performance report, so people could see what was happening on waiting times and cancer waiting times, routine elective waiting times. We also did a couple of specific things beyond the, just making public the Greater Manchester picture of the NHS constitutional standards. And I think we were the first part of the country that published waiting times for children and young people's mental health access at the same time, running, I think, about 6 months ahead of of any national changes. So that principle of kind of transparency, being open about where our access problems are to services, and publicising that should absolutely be expected, I think.
Joseph, you've got your hand up.
Thank you. Yeah, Joe Whitaker from Greater Manchester Coalition of Disabled People. Thanks both very much for the presentations. I think one of the things I would just like to point out that I think is really quite crucial. First of all, I think not to make a trite comment, but in the report there is too many words. There are too many words that have been repeated. And I'm just going to use the example of families of disabled children, for example, who have been subject to the educational healthcare plan. Anybody that knows the educational healthcare plan, which was brought in to ensure that services were actually working in collaboration around an individual support requirements. One of the things that has emerged from that, and you'll talk to many parents of disabled children, where it's been a nightmare actually having to work with the different services who are supposedly working to the same plan. So my question is to both speakers, you know, it is a case of physician heal thyself. How do you get people from the different services, health and care, working collaboratively and sharing a common purpose to actually meet the requirements of the individual, not just disabled people, but people who are requiring that service? The idea of getting those hierarchies, incredibly powerful hierarchies in those services, to actually share, and the focus being on the support that the service that they're providing, is a mammoth task. Nowhere do I read, and I've not read it all. I've not read it all. What I have read tells me I don't see the emphasis and the importance that's given, one, to those services working collaboratively in any meaningful sense. And do the two speakers recognise that as a challenge?
Shall I
Go
on, Mike, and then I'll jump back in.
So I'll do the locality kind of view of it. I completely recognise the challenge of it. As someone who's got a joint role between a local authority and the CCG, I think I spend my life half the time refereeing conversations between people who work in two different organisations. I think for me, we've got to do a number of things. First of all, we've got to transform and shift each of the local systems into a place of collaboration and not competition, in the truest form of what that means culturally as well as practically. I think we've absolutely got to get to a place of having a system-based budget and not organisational contributions, because the reality at the moment is I think the system is set up in a way to enable people to try and cost shunt when pressure comes. And unfortunately, I think we are operating in a world where we've got too much in the northwest of austerity, and the squeeze that puts on different parts of the system at times is quite enormous. I think, third of all, we've absolutely got to get to a place of being granular in the detail of designing services with people and not designing services for people, and really having different conversations about what people's needs are and why that's the case. Too often, I think the statutory organisations assess a need, pull down a range of services and simply leave people to mobilise that in whatever way they want. I think we've got to move out of that mindset into a much more co-created, co-commissioned type of environment in which people are much more in control of their own destinies. I think it's an incredibly difficult challenge, and I don't underestimate it. It's certainly something on our radar in Oldham, but I don't profess to have the solution to it yet, other than we're actively talking about the things I've just spoken about. I think we too often see a healthcare pot of money and a local authority care pot of money, and we need to just see one Oldham pound that needs to be deployed in a way that makes the best sense for the individual on the receiving end of it, and that's really, really hard to do. Accept.
If I just add a bit to that, because and I don't want to, if Joe's not read all of the document yet, I don't want to ruin the end for him. But I've got a feeling you might still be disappointed when you get there, in terms of the clarity of that, the clarity of how kind of individuals really in services and practitioners in services meaningfully collaborate, because I think the national document stops at quite a high level, so I think it'll leave you wanting a bit more, if I'm entirely honest. So definitely back what Mike said, and think about, well, actually, what are the things that are most likely to make practitioners collaborate, and what are the things that have been standing in their way. And some of this is back to Mike's reference, I think, to the heartbeat moment later on, and the fact that I've got a feeling we've got worse at this actually over the course of the last 25 years or so. 25 years ago, I was a neighbourhood housing officer, and I found it dead easy to work with public service partners in a place, and it was routinely expected then. So I always end up being quite surprised that actually it does feel like we've drifted away from that, and it might be down to kind of over specialisation and people not feeling like their particular contribution matches or can be supplemented or complemented by anybody else. It can be regulatory frameworks that pull organisations away from each other in a locality and make them feel that they're not accountable to the to the resident. I do think that one thing we could do in particular, and I think maybe working with some of the colleagues that Joe might have been speaking to around parent carers groups, and thinking in particular about if that kind of collaboration and joint working on implementation and action around EHCPs is a kind of profound difficulty, that might be one area that we specifically pick up and do some work on together in the first phases, and I'm sure that a lot of colleagues in the system would be across Greater Manchester would be really keen to do that, and I recognise, because I think some of the people that Joe will have been speaking to, and so I absolutely recognise the issue, and I think we could do a bit of focused work around EHCPs and gather a bit of the leadership around the system to support a focused effort on that.
Can I just add to that? Sorry, just one thing. I was just looking at the chat about, there is something, I think Warren's sort of made an offer about transference of knowledge and learning into other areas. But I think we're at a really important point when it comes to things like EHCPs and a variety of other different things I could probably put on the table and list. The integrated care document talks about making the ICS the system by default, and whilst I absolutely support that, if that in any way erodes localities, I think that would be an absolute disaster, because a lot of these conversations are in localities, and if all of a sudden the NHS, for example, thinks it could commission everything from a GM perspective, EHCPs, I think, will be in a very, very difficult place, because it just makes the conversation further and further away. So, there are some things that I think we need to be clear about across Greater Manchester, about the importance of place and localities and how that works with GM. But a lot of that working with GM should also be about successfully transferring solutions that have worked in other places around the patch, and that in itself is also quite a complicated thing to do.
So there's just a few questions in the chat. I think the one that Colin has posed, we are probably going to pick up in the discussion group, so I won't go to that now because we've only got a few minutes left before a break and then moving into the discussions. But there's one about how the VCSE sector will be supported through ICS developments in performing the preventative role that it does in maintaining mental health and well-being of populations. And they're particularly thinking those organisations that aren't necessarily place and locality based, but work with particular communities of identity, such as refugee and asylum seekers that might be dispersed widely across Greater Manchester. So that's kind of another complex thing in all of this that doesn't necessarily fit neatly into the locality conversations. So don't know what your thoughts are around that.
Makes me think. I'm not on mute. I think it's a really good point, and I think something that we've recognised together in the work that we've done recently. So I'm thinking in particular of the work that we did, I think supported through Stuart Lucas, around commissioning for inclusion, and the recognition of there's huge value, I think, in it, as Mike's outlined, in how you can connect with communities, in neighbourhoods, in place. But there are, and it could be service areas, or it could be particular communities that are not best served through that through that arrangement. So how do we get alerts to what are the most appropriate kind of cohorts or communities or populations where we might genuinely need to take a kind of pan GM view on coordinating services and supporting consistency. And it could be refugees, asylum seekers. Could be rough sleepers, people that are rough sleepers, or people that are homeless. Could be travelling communities. Could be a range of people, actually. But for us to be alert to where place is not the most appropriate focus for service development. So I suppose the answer is, let's make sure we implement the recommendations of the commissioning for inclusion document that we agreed together, I think, less than a year ago now.
Thanks, Warren. Kat, you spoke about the transfer of where there's been successful relationships with CCGs. Do you feel that the earlier answer kind of went some way to answering that? Great. In that case, unless there are any other questions or hands up that I've missed, I think, Tony, I think your point did actually get answered in the previous one when I explained your earlier question about the reporting that's been done through the Health and Care Board and how it needs to potentially be picked back up. So I'm going to go to a break now.
My point really was that, we now into the 5th year since Health and Social Care and it was delegated to Greater Manchester with a mandate to integrate, and we haven't had any reporting back on governance. And normally when organisations do come together, there are mergers, the first thing that people look for is savings that can be ploughed back. And we haven't had anything. We are in a financially strained environment, and I would have thought that we should be looking for savings to plough back to improve our services.
Well, I don't mind saying a bit about that, because I think, and hello again, by the way, Tony.
We meet again.
It's been a while, hasn't it? So I think the key bit is, I think there has been reporting. So when we came together as a partnership formally in April 2016, what we did, and the only interruption to that really was the middle of last year because of the pandemic, but in 2016, 17, 18, 19, and 19, we held all of our meetings in public, and we published an annual report and the financial accounts in each of those years, and did that on the basis of surplus and deficit in the system. So that information is definitely there. I think we probably need to find better ways of making sure that it's that it's reaching you, but it's in there. And in that context, I think if you remember at the time that we were making the pitch and we were describing a kind of forecast gap of something like 1.9 billion by the end of the 5-year period, we did manage to deliver a surplus in each of those 5 years. So what the government and NHS England got for that devolution agreement, that gave us, if you remember, £450 million of transformation fund money to integrate services, to develop primary care networks, to expand access to mental health across all ages. We delivered all of those objectives and ended up returning all but 8 million of that transformation fund money in surplus back to the national system. And I think in terms of the financial the financial transparency around mental health spend in particular, because I authored a report in the summer of 2017 that publicised for the coming 3 years what the mental health investment standard would mean for each CCG area in Greater Manchester. So there was definitely an attempt to make that information publicly available, to generate that financial transparency, do it in the context of both investment and the financial bottom line. But as I say, maybe we've just not been as effective as we want to be in making sure that that's getting out there and reaching all parts of the system.
Could I have a copy, do you think, please? Because those in mental health in Stockport are not seeing the improvements that you feel have been produced.
Yeah, I'll dig that out for you, Tony, by all means, yeah.
Thanks very much indeed. Okay.
Thanks, everyone. So what we're going to do is take a very quick comfort break, and then when we return in 5 minutes, people will be sent off into some breakout rooms, and we will pick up on the discussions, so looking at what's needed for VCSE organisations to be connected with integrated care systems both at a GM and locality level, and pick up on what Warren's mentioned around barriers and also good stuff that's happening